morning, everybody. My name's Paul. Want to thank a lot of people. We got the PowerPoint up?
Yeah, well, let's ask for cases first.
Oh, okie dokie. But first, welcome. Thank you all very much for being here. I want to thank the University of Nevada School of Medicine and the ECHO program, especially Chris and Troy for all the work you do behind the scenes to make this come together. And then I have Dr. Patterson and Dr. Lewandowski with me, both experts in the field. Dr. Patterson has his own practice specializing in pain management and dealing with chronic pain patients. And Dr. Lewandowski has been a psychologist for over 35 years who specializes also in chronic pain. I am a substance use counselor licensed in multiple states, and this is what I do a lot of times with pain and with opioids and all of the other medications that come along with this situation. Who do we have in the audience today? Can you please introduce yourself? Let's start with
Becky Bailey.
Becky Bailey.
Hi, my name is Becky Bailey. I am with Nevada Rural Hospital Partners.
Nice to have you, Becky.
Thank you.
And then is it Dr. Baltar?
Yeah, hi. I'm a geriatric fellow, UNR.
Well, hello, welcome. Good morning.
Thank you.
And Candy Copeland?
Hi, I'm a UNR student, named my nurse practitioner.
Great, thanks for joining us.
That was a nurse practitioner?
Yeah.
Okay, good. Good to have you.
And Justin Heath?
Hi.
Hi, Justin.
Hi, I'm here in Fallon, Nevada, family medicine.
Thank you.
Dr. Chrysler?
Yeah, I'm just an old timer. Interesting to see if anything's new. Unfortunately, doesn't seem to be too new.
Good to have you, Dr. Chrysler.
All right, Dr. Cole?
Hi, Barry Cole, semi-retired neuropsychiatrist and pain educator.
Wonderful. Thank you, Dr. Cole.
Tyson McBride?
Yeah, I'm a physician assistant out in Lovelock and just really enjoy these echoes.
Great. Okay, good to have you.
And I believe we have Dr. Christensen in Ely. I don't know if we have audio for him today, though.
Oh, hello, Ely. Hello, Dr. Christensen. Okay. Are there any cases you'd like to present? Does anybody have any outstanding complicated cases or anything that comes to mind that you'd like to get some input with? Okay, let's keep this interactive. If something does come up, just raise your hand or type it in. Troy will get our attention and we'll all jump on it and try to give the optimal advice or care possible. And one of the things that really stands out about ECHO is that you don't have to do this stuff alone. A lot of the time when somebody has chronic pain issues, they have an awful lot of things that are going on. And if you're a physician and you only get to see the person for a limited amount of time, the other specialists that are on your team can spend an hour with that person and really dive down into getting to the core issues that come along with chronic pain. And so right now, if you have any staffing issues or anything that is a concern, utilize the power of this group so that you're not alone and you can provide that optimal care by sharing everybody's experience. Okay, so with that being said, on with the show. Okay, so oxy to heroin, how did we get here? Look at this. It's 2017, we're already in November. I was just talking to Chris about how fast this year has flown by. We're already here, November. And then I'm starting to think, how did we get from medications to heroin? And something really resonated with me. I heard that this is a sad time in our history, and it boils down to social isolation. And that made me start thinking about, what are we doing? What are the movements that are going on? What is happening in the country? And how really my focus a lot of times is trying to educate not only older people, but really trying to get to people talking to adolescents. Because whenever I look at an adolescent, they have a cell phone. And whenever they're getting their information, they're getting it in little sound bites. And when I'm looking at addiction, try taking a phone away from an adolescent. That's a behavior that comes along with addiction. And then I'm wondering, who's raising our kids? And then why is society going this way? So when I'm putting all of this stuff together, I was talking to Dr. Lewandowski about this before, it's the, we have so many things to cover in the last 20 years that brought us to this place in time. And one of the things that's really important is medications, opioids, are not to be demonized. These are great medications and proven really effective for acute pain. And a vast majority of your patients will follow your lead, your directions. So we have to be really careful, especially with the verbiage that we use with the medications and the regimen that you put patients on. So we're going to review overdose deaths in the United States, examine the physiological, psychological, opioid use dependence, and discuss treatment. And hopefully we can get through this. If we can't, this is part of a two-part series. We'll be here again in another couple of weeks, and we'll take it from wherever we leave off today. When we're looking at the epidemic of drug overdoses, this started in 2003. You can see this. Of course, my heart goes to that little red dot where Nevada is, straight up from San Diego. You can see that. There we go. And we were already in there. You can see how this epidemic for drug overdose deaths, these are deaths, ripples across the United States, and it gets bigger every year throughout the country. The important thing to notice with this is alcohol-related deaths are not going down. Cocaine-related aren't going down. These are just new things that are being introduced or new movements that are taking over. Here we go with drugs involved in U.S. overdose deaths in 2000 through 2016. And so when we're looking at this, open up the slide a little bit more there, Troy. Look at the 64,000 drug overdose deaths. That's a lot. That's through 2016. Sharpest increase is related to fentanyl and fentanyl analogs. That's the synthetics that you're seeing a lot of. Of course, methadone, meth, cocaine, natural and semi-synthetic opioids, heroin, and synthetic opioids. This is important to recognize because at this point, it's considered an epidemic, and now we're getting the attention from the government and the powers that be to jump into prescribing, not recommendations, but requirements. So we look at 64,000 deaths. We hear these stats all the time, and they're almost mind-numbing. So how do we put 64,000 drug overdose deaths into perspective? Well, let's take 64,000 and And then we have 8,760 hours a year, just divided. So by the time we get through at this hour, there's going to be 7 deaths from overdoses, which is the equivalent of a 737 jet crashing every day. Now, if a plane falls out of the sky once a year or so, that's a big deal.
Big news, yeah.
Yeah, but if we do that every day, that's where we are, folks. This is more deaths than auto accidents and gunshot wounds combined. So, let's follow the prescriptions. The amount of opioids prescribed per person varied widely among counties. These are the counties in the country. Let's go to home. There we go. Okay, and you can see that's black, and then we'll bring it back out. There we go. So there we are. So we're taking the national perspective, and then we're bringing it back home. Now, a couple of you remember that I was at the hospital in ICU the other, about 3 weeks ago with one of my good friends whose girlfriend gave me a call and said, there's something wrong with this person. Come over, you have to try to take care of him. So I arrive at his house, and he had his fibula operated on. Well, when you're younger, a lot of times you just wrap that thing up, and it's not weight bearing, it'll take care of itself. But he went to a surgeon. The surgeon does what surgeons do. He operated on it. You go to get your oil changed, you're going to get your oil changed, right? So he goes in, has the surgery on the fibula. He's 76 years old. If the doctor says to do something, and his girlfriend's the same age, the doctor says to do something, you do it, right? There's no questions. It's follow everything exactly by the instructions. So these are the post-operative medication instructions. I'll go through them real quick and just highlight some areas that really resonated with what got him into this situation. So patients are typically provided medications prior to surgery, so they may be filled ahead of time. The prescription will expire in less than 2 weeks under DEA rules. Please fill them and store them safely at home. Okay, so when an older person sees DEA and it's going to expire in less than 2 weeks, that says get your stuff now. So they run to the pharmacy, they fill that thing up. Further instructions may be given. Generally, patients receive a block from an anesthesiologist. That's the next paragraph. So then it explains you have 2 medications, both of which are double strength. Now, this is somebody who's never had an opioid in their life, and he's getting a double strength 10 milligrams. Now, the 10 mil, when you're looking at Percocet, that comes with the 325 acetaminophen as the combination package. So you also get a medication for nausea, but you got Norco as a backup to the Percocet. So patients starting with the stronger medication and switch to lesser pain medication in a few days.
I find that interesting that, if you really look at converting hydrocodone to oxycodone is not that much stronger. They're almost a 1-to-1 equivalent. And so I find that interesting that they're counting here in this as one being a lot stronger than the other. But if you look at it, in a morphine milligram equivalent, there's not much difference.
Thank you. That's an excellent point. When we're looking at the body, whether it's oxy, like Dr. Patterson's talking about, the similarities here for the power and strength, or heroin, the receptors don't recognize the difference. They're receiving the chemical, and they're going to act accordingly. So when we're looking at oxy's about 2 times more powerful than morphine. Heroin's about 4 times more powerful than morphine. So let's keep that in mind because they all break down really quickly. Now you have longer acting ones like methadone That's a longer acting. But then you also have to wonder if they're using anything else, including the methadone. So here's the regimen that my dear friend is on. Set the hydrocodone aside, okay, and don't mix with the oxycodone. On the evening of your surgery, take a whole Zofran, okay, 30 minutes before bed, and half an oxy at bedtime. 3 hours later, take half an oxy. So they go to bed at 10. So girlfriend, 1, wake up, honey. You have to take your oxy. Okay, I'll take it because it says it right there. 3 hours later, 6 hours after you started, take an oxy with a whole Zofran. 3 hours later, 1, 2, 3, 4. Buzzer goes off. Yes, they had their alarm clock set. Wake up, honey. You have to take your pills. Okay, dear. Okay, this routine, continue this routine until the pain starts. This whole idea is to keep them ahead of the pain, at which time you will increase to a whole Oxycontin. Now, this is somebody who's naive to opioids. You will increase to a whole oxycodone every 3 hours while you continue the whole Zofran every 6 hours. Then it goes into if your surgery is afternoon. Then at the bottom, if you are having issues with oxycodone, such as nausea, itching, too sedated, etc., you can switch to the hydrocodone at any time. It never says stop. It never says discontinue. It never has an exit strategy or what success looks like. It never has a time frame. It just says you're going to keep on doing this until it's done. Most patients believe that hydrocodone is about 25% less strong, but others prefer it to oxy. Don't start your medications and do not get behind once the pain starts. There's no gray area. There's no options here. You'll be a lot more comfortable if you schedule doses and stay ahead, which they did. So when I get to his house, I didn't recognize this person. He was a gray blob. He was sweating. His eyes were rolling back. He couldn't form a sentence. We need to get this guy to the emergency room. The emergency room doctor said we were 1, maybe 2 pills away from an overdose situation. What happens when they're older, and we talked about this at another echo program, was the acetaminophen is what's closing down the liver. And then that impacts the kidneys. So you have the constipation from the opioid, and the liver's being closed down by the acetaminophen. You also have dehydration. You have a toxic environment being created. Now he was in the ICU for 3 days. This hospital stay, it was for 5 days total. And he says he's back to normal mentally, but that kind of assault took a big hit on his psyche. And he's a guy with a lot of swagger, but it really impacted him emotionally as well as physically, because he almost overdosed. And this is not the kind of guy who's living under a bridge with a needle in his arm. This is the kind of thing that we have to look at when we're looking at somebody who has opioid dependence. Now, when we're looking at addiction, you might want to avoid that word. Try to look at dependence, physiological and psychological. A person really doesn't have a choice. If they had a choice, they wouldn't be addicted or dependent. They don't want to be held hostage by this. But you can see by somebody who's following this by the book can really get into trouble. Now, I talked to the physician's been talked to, and so they're switching up their words. But this is something that you want to be careful about when you are prescribing and sending somebody off with these narcotics. Any questions?
I got a comment. It's interesting. A lot of the chronic pain patients that I see will come to my clinic, and we got to remember that those statistics that Paul was showing earlier are unintentional overdoses. So these patients weren't trying to kill themselves. And a lot of times I'll see patients who come to me that I believe they're on a very unsafe regimen. You know, they'll be on soma, a pain medication, and then a benzodiazepine. And a lot of times I'll tell them, like, look, this is an unsafe regimen. You know, we need to get you off your benzodiazepine. You know, let's stop the soma immediately. I'll give you a different muscle relaxant. And then we talk, you know, after those, if they're on an unsafe morphine milligram equivalent, about weaning down. And a lot of times the patients will look at me like I'm crazy and say, Doc, I've been on this for 10 years, and you know, my body's used to it, and an overdose is going to happen to me. Well, I can tell you in 2 or 3 different cases where patients have been referred to me after they've had an overdose of being on that type of regimen for 15 years. And what ends up happening is you know, it's a chemical balance in your body. And as we get older, you're exactly right, our kidneys and our livers don't work as well. 2, we're probably having, you know, more medications added on by our physicians to treat underlying issues, because it's only natural that as we get older, we have cholesterol, blood pressure, or other disease processes ongoing. And so even though you were on those medications previously, adding other medications may inhibit or compete with the enzymes that break down these medications. And then lastly, you know, I've seen cases where a patient ends up with a simple UTI, urinary tract infection, and I get a phone call saying, hey, you know, what are you prescribing? Your patient is at the ICU, or, you know, came through the hospital, is in the ICU, and they overdosed on the pain medications. And I'll go back and look at the patient's records, and they've been on the same medication for 2-3 years. And I'm telling them, look, I haven't changed their medications. And so a lot of times what happens is either the antibiotic or it's the way their body reacts to that urinary tract infection. It can make that drug more readily available in their system. And so I try to explain this to patients. Like, look, you know, you may be taking these as prescribed, and it may have been safe for 10 years. But one simple change in your body physiology, and you may be, you know, in the ICU with a ventilator, on the ventilator.
Yeah. But, and then you, like you were talking about, this person has diabetes too and is overweight. So you can see that everything is compounding. Then when we look at the aging process between 30 and 40, it's really not that dramatic. But from 60 to 70, you're saying everything ages a little bit faster. Another thing is, when you're talking about the trifecta, the somos, the benzos, and the painkillers, these are opioids right now. The next big push you'll probably see that's kind of predictable is on benzos. That's coming. So how did we get here? What happened? Okay, so quick, this hasn't just happened overnight. We didn't just wake up and everybody's on opioids. This has been a calculated sales strategy for about 20 years. Purdue financed pain is the 5th vital sign. This is a brilliant marketing campaign. It's to help marketing OxyContin. So they have their drug, OxyContin, and they're wondering, how do we market this thing? Well, if I have one pill that will take care of pain for 12 hours, and I create the need or the perception of need that it's a vital sign, it's brilliant. Now here's what happens. For blood pressure, pulse, temperature, and respiratory rate, you absolutely need those. Without those, you die. For pain, they're demonizing pain and saying you are supposed to be pain-free. And it's subjective. So you tell the doctor if you're feeling any pain. The doctor then has the obligation, especially if they're getting rated on Press Ganey or any of those surveys, you have the obligation, doctor, to make sure this person doesn't have any pain. Okay, so put a happy face here if you don't have any pain. This was approved by the Joint Commission on Accreditation of Healthcare Organizations in 2000. So 2000, we're at 2017, there we go. Now, we have one pill. It'll take care of 12 hours of pain relief. But we're starting to have some breakthrough pain. This strategy brought the two doctors who were running Purdue Pharmaceuticals into the wealth category of the Rockefellers and the Mellons. They said, with breakthrough pain, you titrate up from 40 milligrams to 80 milligrams. So if the person's taking a 40 and they're having breakthrough pain at hour 8, you increase the dose to 80. Well, we know this is not longitudinal. We now have higher peaks and lower troughs with the opioids that are being introduced, meaning that there's more euphoria and deeper withdrawals. So now we've started that addiction cycle.
Hello.
Hello.
I had trouble getting to ask you a question. If we can back up a bit.
Yep.
The case you presented, unless I'm missing something here, you got to treat the doctor, so to speak, not the patient. The patient you can take care of easily enough if you get there. So the question is, did you speak, when you spoke to the doctor, what kind of response did you get, number one? Does anybody look at the practice trends of this physician? Does AB 474 really going to change the practice of this type of physician? And what are the penalties? From what I can see in AB 474, there are no penalties. So yeah, we can get back, you know, anybody in pain medication, and I think Barry Cole was one of the first to start it, to get people who, if they're going to be in pain treatments, doctors, they ought to know the basics, they ought to know the rules, they ought to know the ethics. And like I said, I'm an old timer, I don't see much change. So Barry, do you want to comment on it? I mean, is there a physician monitoring? Who takes the lead? I don't expect you guys to, but I do expect the board of medical examiners, whether it's the osteopaths or the MDs. We ought to have a single board. Does anybody really? We got at least one doctor in the state legislature who smiles, spins around, nice guy, doesn't get anything done. You know, who's going to take the lead? Who's going to make sure that, you know, going back, I've been around a long time. I had a fractured proximal tibia. It was insignificant. My spiral fracture of the tibia, you know, was important, but the fibula, who the hell operates on that to start with?
Right, that was my question.
You know, I can laugh about it in the locker room, but, you know, or I had a neighbor next door who's now in a care home. She came wobbling out to the mailbox, and she had a little stiffness. She's in her 80s at the time. Yeah, she wakes up stiff and has some thing. She goes to a doctor. Now, you can call me racist or whatever, or, you know, it just happens to be somebody from a different culture, from a different country, from a different perspective, who gave her oxycodone to take for her pain. I didn't know that. I said, Marge, what's your problem? You know, you can't stand up. I don't know. Somebody, they gave me some medicine to take before I go to sleep. I look at the label and I said, holy Christ, stop the damn thing. I mean, you know, who is monitoring the physicians? Who's going to make them accountable?
Dr. Cole?
I mean, the rest of the stuff that you're doing is great. And the people that go into pain management should have to take a certifying exam to show that they understand at least what they're doing, even if they don't follow the, you know, the obvious parameters of what they should be following.
Well, we have this is why CDC guidelines are coming up the way they are, and we have the PMP that is supposed to be monitoring. Then we have SB 474. Did you have anything?
Yeah, I was going to say, so, I mean, the monitoring piece here, a couple things. One, so they are, with Bill AB 474, the PMP, so let's say, you know, a physician's prescribing more than 365 days. I know that there are triggers in there to red flag that physician, which then that goes to the Nevada Board of Pharmacy, which then I think turns that over to the Nevada Board of Medicine. So I think there are some triggers within AB 474 that if there's overprescribing or something doesn't look right, it will red flag that physician, which then the Board of Pharmacy turns over to the Board of Medicine. But you are correct. Besides certain parameters, there really isn't any way to monitor. I think usually how they catch these things is there's a patient complaint that goes to the Board of Medicine. The Board of Medicine then requests records, and then they match it up versus what the physician's doing versus what state law is. And I think you're right. Sometimes it's just pure circumstance on how they catch the physician. There really isn't a lot of checks and balances moving forward with these laws. Just puts a framework in place that they expect you to abide by.
I happened to speak to, inadvertently, I wound up talking to the physician who's for the state, who's the head of Health and Human Services. You know what his response was? What, do you want me to go ahead and prosecute him? You want me to be the overseer? You want? And I said, yeah, exactly. Well, he didn't like that. And he is not going to take that responsibility. So the question is, who is? I would say you guys are obviously interested, and everybody else that does pain medicine should be interested in getting rid of the bad apples. So who's going to present, you know, I don't think the legislators have a clue. No.
Yeah, I think a lot of these bills that they're passing, all they're doing is deterring or trying to deter primary cares from prescribing, which then means you're exactly right. I mean, a lot more referrals towards my clinic. I mean, there's days that I show up at the end of the day and there's a stack of 20 patients sitting on my desk. You know, that's impossible, you know, in a month. Some months we may get 250 referrals. Do you think we can handle 250 new patients a month? Not even close. Even with myself and other physicians in 4 or 5 mid-levels, you know, we may get through 65 or 70 new patients in a 30-day span. Interesting enough, we recently had a patient refer to us, and it took us 2.5 weeks to get in. That's good. There's sometimes you wait 6 to 8 weeks to see me, and the patient turned us into their insurance company saying that we didn't see them fast enough, and we got a letter and complaint and had to justify why it took us 2.5 weeks to see them. So I mean, it's you can't win on either side, and that's what's going to happen here. Is I think more and more of these laws are going to deter people from prescribing. They're going to dump these patients, which then, you know, what do the patients do in the meantime? It's not their fault that they got started on these medications in some circumstances. They don't understand the dependency part of it, and they want to avoid the withdrawals because they don't know what's ongoing. And they're kind of left high and dry because these physicians, you know, are dumping them off at the curb.
The comment before I shut up is that you missed is, you know, why are we having this increase in use of opiates and all the rest? It's the culture. I mean, how can you, not one medical organized group in Nevada stood up and said one word when Sagerblum, the lawyer senator, was pushing marijuana for recreational use? Nobody. So how can a youth walking around with a cell phone and everything else take it seriously when you say, you know, don't use it, be careful and all of that? You can go out and buy it. And, you know, you can argue until it's blue in the face, but it's not innocuous. It's part of the continuum. It should never have been there. Anybody that, doesn't accept that premise, I wonder if they should be in medical care. It doesn't make sense to me. So you put all this together, we have nobody taking responsibility, taking leadership to really educate the legislators, make it mandatory penalty for those that don't follow stuff. Ask Barry. He's pretty quiet this morning. He's probably saying, I've been there, done that. I'm tired.
Well, thank you, Doctor. The thing with marijuana, just to put it into perspective, at least we have the FDA to regulate and CDC. A marijuana industry is regulated in this state, not by the FDA, not by anything medical, although they like that name. It's regulated by the Department of Taxation. So we need to, I guess, educate them too. But they made $3 million in the state off of the $27 million that they made in 1 month, I heard. So it's capturing that adolescent market. I think that's what you're talking about. And they're doing a fine job there.
Hey, this is Barry Cole, if I may jump in, since Len's thrown down the gauntlet, as it were. First of all, what you learn when you work for the Division of Mental Health, Mental Hygiene, which has now changed names, but the doctor that I think Len is talking about is the head of the whole health department for the state of Nevada. The philosophy that governs pretty much everything at the state level is never assume ill will, because usually ignorance and stupidity is the explanation. So it isn't that people are going at this, willy-nilly and for bad reasons. What we're faced with now is none of us officially learned to do pain management unless you were crazy enough to ever do a pain fellowship, and we are few and far between, which means the burden of managing pain in the US is based on primary care medicine doing the lion's share of it. So evaluation and mitigation strategy, they refuse to require it unless you prescribe a specific agent, a medication that comes with a REMS requirement. But in general, nobody's ever been trained in pain medicine. We all just sort of wing it. What we knew in the 80s, and nobody wants to go back and admit, Mike Lewandowski, you remember this at the Sierra Pain Institute. Pain goes down when you wean patients from opioids. Opioids are for short-term use. They are for cancer use. They were never intended for chronic maintenance therapy. This whole experiment was ill-gotten. I launched OxyContin in 1996. I relaunched it in 2010 in the reformulation. Some of the things that I've heard are factually not correct. It was the VA, guy named Bob Kearns, who pushed pain is the fifth vital sign. Yes, Purdue opportunistically funded some of those activities about 99, 2000. But by then, the Joint Commission had already bought in. So had the Federation of the State Medical Boards. Many state medical boards began taking action against physicians. And we live in a complaint-driven system where if somebody denounces you, yeah, the pharmacy board gets excited, the nursing board gets excited. But even back in the year 2000, Keith McDonald was saying Nevada's biggest problem was hydrocodone. If you divided the number of hydrocodone dispensed in Nevada by then the population, every Nevadan received 43 Vicodins a year. I never got any. I'm still upset about that. Somebody got my Vicodin. And then the other issue was that when we look at what could be done, there's so much that could be done to correct this problem. Nobody is willing to focus on what's happened. It's no longer a pill problem. It's that you've now got organized crime has moved into this. We're moving not to OxyContin, We're moving to heroin, we're moving to fentanyl, we're moving to carfentanil, and all of the solutions to get prescribers to stop prescribing doesn't matter, because I can tell you when I look at a urine drug screen if you're or not, because it's always cross-contaminated in the north with Molly and MDMA. And if you get it sourced out of Las Vegas, Clark County, it'll have both Molly and a little bit of LSD contaminant. So we can now see that the Chinese are involved, the Mexican cartels are involved. You know, I'm not work because you can fly it in through like a million different ways. And that's what's happening worldwide. Chinese making fentanyl, carfentanil. I was over in the Philippines 2 years ago. They have a big, and he now treats people with drug problems by killing them. I don't think we want to do that in the US, but it's sort of a fascinating problem that, back to the original statement, never assume ill will for what's better explained by the ignorance and stupidity around us.
Yeah, and I think you're exactly right. I mean, now it's what happened over, early 2000s to 2010 is there's that patient or that physician education part. I'm sure primary cares went to conferences and they hear, hey, you need to treat your patient's pain. You need to aggressively do this. And then, you have the legislation and the HCAP scores and all that to back it up to tell physicians to prescribe more. I mean, just as 2 years ago, I know a physician that was over in Kaiser in California, and he was working the urgent care, and with, this evolving opioid crisis, he's only prescribing opiates for the patients who need it or deserve it. And say a patient would come in with a sprained ankle, he would tell them, the Price principles: pressure, rest, ice, compression, elevation, and maybe give them an anti-inflammatory. Well, 3 months into the job, his administrator pulls him aside and says, hey, your satisfaction scores are terrible. You don't get a bonus this quarter. And guess what that did? He told me straight out, he's like, everybody who comes through the urgent care now gets a script for pain meds to go. I've gotten a bonus every quarter since. So there's this network that's been set up over the last 1 to 2 decades that needs to be broken down. I mean, it's incentivizing physicians to do the wrong thing. There needs to be more physician education in the other direction. I can tell you another negative experience I had is a patient I caught doctor shopping. Patient thought they needed 14 hydrocodone a day. I mean, the Tylenol on that alone is not right. And, I weaned the patient down to 4 a day. And all of a sudden one day I checked and this is before it was mandatory to check the PMP. I checked them twice a year. All of a sudden pull up and I see that the patient's getting, 120 pills from me. But on top of that, they're getting 120 pills from the primary care that referred them over. So I called the primary care and I'm like, hey, when's the last time you saw this patient? Turns out they haven't even seen him in 8 months. You know what it was? The primary care told me I wasn't doing my job. The patient called and complained about me. And so she was calling in the hydrocodone for her every month to make the patient happy while she found her another provider.
Nice.
Even though I'm doing the right thing, this primary care's undercut me, and the primary care was telling me I didn't know what I was doing. I offered to take that primary care to dinner to teach them a little bit more about pain management. They told me they didn't have enough time and hung up on it.
And if I could add to what Dr. Cole said, it's interesting because in the 1980s, when we were really doing interdisciplinary pain management care with Dr. Richard Cronin and Barry Cole, people were getting better and they were getting off the meds.
Yeah.
Right. And so, essentially what I think we need to do today is, my new mantra is, teach skills and reduce pills. It's very much about developing other ways to deal with pain rather than passively taking a pill. And we had good evidence that what we were doing in those days was making a difference. And that was in the 80s.
Yeah.
So
I agree. I think nowadays we're in a, what can you do for me now society. Nobody wants to put the work in to get better, and everybody thinks that they're entitled to taking a single pill to feel better immediately. Nobody wants to put in the work. mean, so I think it's not even just this movement, but I think it's the way our society has gotten to this point that everybody thinks that they should have the answer at their fingertips immediately.
Hey, let me just add one thing. Richard Croning taught all of us back in the 80s. Richard used to say to new patients, I have never cured anyone of their pain, and I dare you to be the first. The corollary was, don't even focus on pain reduction. Focus on functional improvement. So when I get a PSAT score, if I'm even challenged to play this game, I demand that they look at function, not at the patient's elimination of pain or the number of pills that I prescribe, because those are false.
Yep, agreed.
Okay, really good. Now, let's just put it into perspective. What slide number are we on? Eight. Okay, remember 8, because we're going to buzz through a couple of these real quick. Control. There we go. Okay, so we were talking about heroin and fentanyl. This is a lethal dose of heroin. That's a lethal dose of fentanyl. Now, Dr. Cole was talking about carfentanil. Has anybody seen 2 grains of salt? That's enough to overdose me. That's how powerful it is. When we go back to and he was talking about all of the products that are available. If I am on the street and I need heroin or I need a fix, and I found out there's some really good stuff here, even though people have overdosed on it, my thought process is they can't handle it. I got this. That's the most dangerous 3 words that you can hear in my specialty. I got this. You're looking at somebody who's in a lot of trouble. But if you get some fentanyl that's disguised or sold as heroin, because really you're not able to see the ingredients. They don't really come with the ingredient label on the side, like how many carbs is on here and how much heroin's on here and all that stuff. You're taking it, you're hearing good stuff about it, and you're finding out that it's cheaper. You're going this way. Then I just want to buzz through this because this is where we were talking about. Okay, here we go. Working with patients. If you tried to tell somebody, and I'm going to throw in benzos anyway, because I have somebody who I'm working with who has he's been on benzos for 20 years. He's up to 3 milligrams, and he came in looking for his 4th. Because the only answer, if you're doing maintenance therapy with opioids or benzos, is more. If you're selling heroin and you want to start up your business, where do you go? You go to a methadone clinic. They're lining up in the morning to pick it up. Everybody is on it already, and they're either supplementing or they know somebody who's going to use it, and you could be the person who gets them back hooked on, as opposed to the titrating them down, because that's a maintenance therapy. And it works for some people. But if you try to tell somebody that you're not going to provide them opioids, or it might be bad for them after they've been on it for quite some time and they build up their tolerance and now they're dependent on it, there goes your lunch break, because this is going to take time. And you are going to be backed up now. It makes the patient upset, just like we were talking, Dr. Patterson was bringing up. Yeah, okay. You're going to get a complaint, Press Ganey. There goes your bonus. We were just talking about that. Then the patient leaves, and so you're out. This is the system that is set up. This is, now, if you play by the system's rules, everybody makes money. The insurance company, the patient might be, they might think they're happy, but they're not getting they're not getting well. Go ahead.
The other thing about the lost patient too is, I see this all the time that I'll have either an abnormal drug screen or some issue, and I immediately after the patient leaves, I'll call the primary care and say, hey, this patient had this abnormal drug screen. I'm going to send it over to you. I'm assuming the next place they're going is back to your office after me seeing them. And I can't tell you how many times I'm surprised that, that patient, has an appointment 4 weeks later, that when they no-show to that appointment, and when they've already no-showed, but yet we've already run the PMP, and I've seen that even though I've called this other physician, they've gone back to them, and that physician has continued to prescribe to them, what I called and warned them about the month earlier, the abnormal drug screen positive for meth or positive for that. They go back to that primary care, and the primary care continues the party, even though I personally called them. That's where I think we need to work together. Like if I'm reaching out to you and I think there's a problem, you probably need to back up your fellow physician. I think a lot of times these physicians feel obligated that they need to redirect that patient to another pain management doctor. And I don't even think when they refer them to the other pain management doctor, they're upfront in their records that, oh yeah, they were positive for meth. Obviously there's not going to be a relationship with me and that patient, but send them to another, pain management doctor with, hey, they're positive for meth. What else can you do for them? Or how can you help them get off these meds or redirect them? I mean, I usually, I've even been on the other end of that where the primary care redirects them to me. Records make no mention of them being positive for meth somewhere else. And then I get them and I say, oh, it looks like you were seeing pain management before. What happened there? Oh, we just didn't get along. And then I request the records. I take over prescribing that day, request the records, and a month later I found out they're positive 2 months earlier at another place. I mean, I feel like I got sabotaged at that point because now guess what? I'm moral and ethically on the hook because I prescribed them 30 days earlier. It's we need to work together and have each other's backs.
That is a really good point. Also, when you're creating your team, when you have a psychologist and your substance use, and putting your team together who can attack these issues, you want to make sure that everybody's on the same page and that everybody has the same philosophy. And when we start off like working with patients, this seems pretty doom and gloom. So let's just look at solutions. I'm not just going to leave it hanging there. Oh, that's pretty bad. Okay, see ya. Solutions. In the beginning, define what success looks like and the time frame. Set up that time frame and make sure everybody on your team understands that for acute pain, you're going, like you break your bone. Well, you know what? The bone is hurt for a reason. The bone is hurt so that you will be easy on it. There's a disease type that people do not feel pain. Does anybody know what that disease is? It's leprosy. And with those people, we feel so uncomfortable with them, we picked them up and put them on a colony and let them go on their merry way. But the idea there is they were chewing through their mouth. They were chewing off their tongue. They'd run into a tree, get gangrene, their arm would be diseased and fall off. Okay, so pain is not a bad thing. Pain has been part of our evolution, and we've needed it to keep us to survive. And now we're in anti-pain, anti-emotional or physical pain. You can't feel anything uncomfortable, which is really a deterrent to our health. Then we have to define what the exit strategy is. We're going to start you on this, then we're going to titrate down. And in a couple of months, you should be completely done with this. And you know what? You broke your arm. It's going to suck. You're not going to be able to sleep some nights. You're going to be really sore and tender. Physical therapy is going to be difficult. Like Dr. Lewandowski is talking about, you have to get accountable. You have to own your own health. You have to be part of the team, and you have to put in the effort. So when we're doing this effort, yeah, that's the healing process. And you know what that pain is? It's telling you that your body is working and everything's going to be all right. Dr. Patterson has a great contract/agreement with his patients, and it details every single thing that there's going to be an agreement here. We're both going to work together, and this is what's going to happen. Get a substance use specialist and a mental health provider. Again, we can spend an hour with the patients. And our time is time limited. The education is important, and that's just to let people know what the pain is doing, why they're feeling agitated, why they're feeling depressed, why they're feeling angry. Oh, your amygdala is starting to wake up now. Or all of the other areas that you've knocked down in your brain are starting to wake up. These are things you need to be aware of, and these are things that you can expect. So a couple of sessions with me, and it's pretty much, okay, well, you know what's going to happen, unless it's like benzos, where you can look for maybe months of withdrawal symptoms. So create your team approach. Not all practitioners are created equal. Test your practitioners that are going to be on your team. Test them for knowledge. Test them for their bedside manner. Test them for their philosophy. Qualified and knowledgeable are different. I think Dr. Chrysler is referring to. Know the team members' philosophy and help patients take an active role in their health care. Let me see if I can. Oh, I'm getting the wrap it up sign. Okay, so I'll just, we're less than 5% of the world's population here in the United States. We consume over 90% of the opioid supply, 95% of the hydrocodone produced. And once we get into opioids for maintenance, you're looking at the long term, because there's no ceiling for opioids. The only answer is more.
Hey, this is Barry Cole. Let me just say one thing about that comment, no ceiling for opioids. There is. It's called metabolites. And the metabolites can cause a world of problems that make taking any more of the identified opioid impossible. The other thing I wanted to bring up is don't ask so much about pain. Ask patients, what will you be able to do when your pain is adequately managed? And then make them pin down things. Walk a block, carry a grandchild, have sex with someone, pick whatever they want. Monitor for when they can do those things and see them as the markers of treatment success.
Brilliant.
Thank you. I think the other ceiling is death. I think that's what we've learned. That there is the ceiling is an accidental overdose, and we're seeing greater than 60,000 a year as of now.
And if I could be so bold, it's skills and not pills.
Yeah, very nice, very nice. We will continue on with this next time. Please bring some cases or staffing. And thank you all very much for your comments and the education. This is a really good session. Appreciate everybody.
Yeah,
thank you very much.
Hey, thanks for your presentation and the great discussion today.
Thank you, Dr. Cole.